We treat a sucking chest wound. Cover it with what? Vaseline gauze. Okay? And then what do we want to do on top of the Vaseline gauze? Tape it on 3 sides. Okay? Again, why do we only tape it on 3 sides? Let air out, especially if it turns into a tension pneumothorax where that flap starts closing. Once that pressure gets high enough, it'll push its way out. Okay? Some places are still using the Ashman seal, but we're not using that as much anymore. Okay? Hemothorax. Instead of the lungs filling with air, they're filling with blood. Okay, we're going to see a lot of the same symptoms when we talk about respiratory compromise, but you're also going to see the hemodynamic compromise. How much blood can we put into the pleural space? It's about 1,500 cc's per side. So people can lose a lot of blood into the pleural space. So again, you can see the sign what we're associated with hypovolemia, flat neck veins. Okay, as the circulating volume goes down, you're going to start getting that anxiety, you're going to start getting that confusion. I know you guys listen to the breath sounds on every call, so you're going to hear decreased breath sounds. I know you guys percuss the lungs all the time, right? So when you percuss the lungs, you're going to have dull sounds instead of hearing the drums type of thing. How do we want to treat a hemothorax? Bring them to the hospital, but something else you may want to do is you may want to consider, do I need to do pleural needle decompression? Because as the bottom fills up with blood, where may all that blood get pushed? Where may all that air get pushed? To the top. So again, so if we do a pleural needle decompression and we at least decrease some of that pressure at the top of the lung area, you may get partial lung filling. So again, you got to look at your patient and figure out what's the best for them. Think about the process of what's going on when you have a hemo or a hemopneumo and determine, is it appropriate to go ahead and do it. Now, again, you're not going to get blood out of here. Okay, when they do chest tubes for hemothorax, they go low because blood will drain out by gravity. It's not going to go up like air is. So again, if you were to do it and it was pure hemothorax, you're not going to let anything out. But again, if your patients are having respiratory compromise, maybe doing a pleural needle decompression may help them.
I know there was a reason they said you couldn't, but I just can't remember what it is, but you can't do CPAP on it. I don't know why.
Because then you're increasing the pressure in the lungs, and if they're bleeding from the lungs out, remember continuous positive airway pressure, you're keeping that out, so you don't want to do that in.
Right, because my only thought was you're keeping the blood from filling the entire lung, so that's all.
You have higher chance of pushing it out also, pushing more blood out. You're not going to compress that to allow for more lung pressure, so that's why they don't want the positive air pressure used.
Okay.
Okay? Again, titrate to peripheral pulse, 80 to 90 millimeters. Again, titrate to what your desired result is. Okay, and as we said, monitor for tension pneumohemo. Tension pneumo, this is where you have that simple pneumothorax where instead of the air going in and out with every breath, it goes in, doesn't come out. Every time air goes in, you have increased pressure. Distended neck veins, tracheal deviation, diminished breath sounds, eventually will lead to shock. When do we see tracheal deviation? Early, mid, or late? Late. Again, think about how much pressure it takes to move everything in the chest, including the trachea, the heart, the other lung over. That's a very late and ominous sign. How are we going to treat that? Pleural needle decompression, right? How quickly does it take for pleural needle decompression to work? No, I mean, you do fluid needle decompression, how long before your patient starts feeling better? Very quickly. Did Sarah show you the video from inside when we do fluid decompression, what's actually happening? It's real short, it's pretty cool. It's right here. Tell me if you guys saw this, you should. Does this look familiar?
Yep.
No. It's a short video, we'll leave it. So this is what they actually did, was they actually put a camera inside their chest, inserted the needle. They'll pull the needle out. We start having the air leaving the chest cavity. And within a couple breaths, you're going to start seeing the lungs expand.
Yeah, that's pretty cool.
I guess you can take a second and try doing that here. We're close. But again, I thought that's a cool video because we always talk about what we're doing, but this actually shows. And again, within 5 or 6 inflations of the lungs, that lung was fully inflated. Okay. So again, within 15 or 20, within 5 or 10 seconds, your patient should be stating that if they're awake and alert, telling you they're feeling better. Cardiac tamponade. Typically, we have the pericardial sac, which starts filling up with fluid. A lot, if we're talking about trauma, a lot of times it will be filling with blood. This will affect the heart's ability to fill, to expand. So we'll see hypotension, neck veins distended, muffled heart sounds, paradoxical pulse. What can you guys do for this pre-hospital? We're not on Chicago Fire. But that is what they will do for them. But this is something, if you identify it, that you should be giving in your abbreviated report, so that doc can be standing at the bedside with the needle to go in and drain this. How much fluid, when you have a patient that goes into cardiac arrest from cardiac tamponade, do they have to withdraw for that patient's heart to have enough space that can start beating again? It's between 30 and 50 cc's. It's not a lot of fluid that has to be taken out. So again, with some of these things that you can treat pre-hospital, what we're looking for you is to be able to identify so that they can be ready for that patient when they get to the ER. Myocardial contusion. We talked about this when we talked about cardiogenic shock before. Blunt chest trauma. Okay? Again, when we talked about what cerebral contusion was, again, you have hematoma and edema and swelling of the tissue. So you have somebody who hits the steering wheel, somebody who gets hit in the chest with a baseball bat, and there's no other injuries. Chest pain, dysrhythmias. This could cause a person to go into cardiogenic shock. You have somebody who has blunt chest trauma with no other associated injuries, but they're in cardiogenic shock. Assume myocardial contusion. There's nothing else. Yeah, they got hit in the chest with a baseball bat. They don't have a flailed chest. As far as you can tell, they don't have a ruptured sternum, but for some reason their blood pressure's down. Got good breath sounds, right? So you don't have a pneumo or a hemo. What's going on? They probably have myocardial contusion. Again, not a lot you can do pre-hospital, but the idea is to be able to identify and let the docs know what they're getting. Head and spinal SOP. Stable versus unstable. We want to do glucose. Why do we want to do glucose so quick in head and spinal injuries? Remember, the brain doesn't store glucose. If we have somewhat decreased blood flow or something like that, we want to make sure that the healthy tissue has enough glucose that it carries on and we don't run into other issues with that. Fluid challenges. Again, this is going up to 500 cc's. Again, titrate to desired response. What is our goal whenever we give a fluid bolus? It's not always blood pressure. So again, figure that out when you're starting your fluids. When do I want to stop? If they start deteriorating, we're going to bag them, consider drug-assisted intubation, and then we're going to give Versed. Infield spinal clearance. Again, I wish Dr. French and I had written up a much easier one than going through all this. But remember, we really have three categories, right? We have the patients who don't require any spinal mobilization. Low risk, no complaints, right? No spinal mobilization is required. Then on the other spectrum, you have the patients who have high risk, mechanism of injury. You have patients that are symptomatic, they require full spinal immobilization. Patients that are unreliable or just have distracting injuries may require full spinal immobilization. Okay? Those numbers should be very far and few in between. Right? We should not have a lot of people requiring full spinal immobilization. It's those ones in the middle that we have to decide how do we want to treat them. Okay? So we're talking about medium to high risk injuries. We're talking about patients that may have some symptoms, but 95% of our patients that have symptoms, in the neck or something like that, what type of injury do they have? It's musculoskeletal, right? They twisted their head or something like that. The majority of our patients, again, even when we were talking about head and neck and head injuries before, what, 2% of them have spinal injuries. So those numbers are very low. So you pull up on the scene and the guy's sitting on the curb or he's still sitting in the car, and as you walk up to him, he turns his head to look at you. Is that a good sign or a bad sign? That's a good sign, because what do we do when something hurts? We don't move it, right? It's a built-in defense mechanism. So right there, that tells you something's good. So we're talking to the patient, we're observing the patient, and we're touching the patient. And what are we looking for when we touch the patient? When we look at talking about infield spinal clearance or determining level of spinal immobilization, what are we palpating? The spine. And what are we looking for? We're looking for point tenderness or deformities, right? If you're running your fingers up and down their spine, does this hurt when I push here, push here, push here? No, but yeah, my neck really hurts. What are the odds that that's an unstable spinal injury? How are we going to manage those patients? Collar, what else? Padded backboard, otherwise known as a stretcher, and we're going to take their head down. Right? Any questions? We've been doing this a couple of years. Have there any issues with that, the modified spinal immobilization? Okay, excellent. Region 10 field criteria is going to be changing in the SOPs. Okay? We'll go over it a little bit more. One of the things I want to talk about that you're going to see on there is you're going to see when we get down near the bottom, it's going to say EMS provider judgment. Okay? We're going to let you guys be part of the decision in some of these cases. So we talk about here, where is it? What's one I'm looking for? Penetrating trauma, injuries to the head, neck. Oh wait, no, where's the one I was looking for? Oh, I think they reworded it in the new one where it's penetrating trauma above the elbow or knee would be considered a Category 1 trauma. So per paramedic judgment, you pull up on the scene. Yeah, somebody got stabbed with a knife in the upper arm, but there's no bleeding. Per your judgment, is that a correct Category 1 trauma? No. So we're allowing you. So again, we're going to start talking about more of this next month as we roll it out. Again, you guys don't need to follow the cookbooks. Anytime you guys want to change an SOP, you know, because you think something's better, you have the right to call medical control and say, hey, we think this is better, right? Because you see the patient, they don't. Okay, so those are the things that we're going for. But the way it's written right now, Category 1 goes to the highest level trauma center within 25 minutes for you guys at St. Francis or Evanston. Okay? Even if you're as close as you could be to Skokie Hospital, Category 1 comes to Evanston or St. Francis. Category 2 related more to mechanism of injury and comorbidities. We talk about anticoagulants. We're talking about 4 medications. What are they? Coumadin and warfarin are the same thing, so that's one. What else? Lovenox is an antiplatelet. Okay, it's like heparin, it's an antiplatelet, it's not an anticoagulant. What are the 3 other anticoagulants?
Eliquis, Xarelto.
Eliquis, Xarelto, and... No. Starts with a P. Pradaxa. Okay, now people a lot of times ask, what about Plavix? Again, Plavix is more of an antiplatelet, but what I would tell you is if your patient's on Plavix, and they fall down and they hit their head, let them know, and half the docs say, yes, Plavix should make them a Category 2. Half the docs are saying it shouldn't. So I would say add that one in also. Just let us know and let the docs decide how they want to manage that. But at least you're giving them the information. But in general, Lovenox usually won't make them a Category 2 trauma. Aspirin is not going to make them a Category 2 trauma, in that alone. Okay? Those go to the closest trauma center. Traumatic arrest goes to the closest trauma center. Okay? No airway goes to the closest comprehensive emergency department. Again, in this area, that's not an issue, right? Everything in Region 10 is either either level 1 or level 2. So you don't really have to worry about just choosing a comprehensive emergency department. But again, next month, we're going to try rolling it out this month, start teaching about the new trauma stuff, but the rollout date for that is until August, so we're going to push it out next month. Let's see. Or is it? I think it's this month. Yeah, no, in June we're going to do it. Drug-assisted intubation. Systemic, airway critical thinking skills. Systemic method problem solving. Do you have time to prepare to intubate? If you are the person doing the actual active intubation, do you have time to prepare and think about what you're going to do? Yes. How much time do you have? From the time the decision to intubate is made, how long do you have? Per the SOPs. And again, I'm saying per the SOPs because that's what we're talking about. How long do you have to prepare? 3 minutes. Why? Because pre-oxygenation for 3 minutes. So again, you should have time to prepare all your equipment so you're ready to go. You have time to consider, are there facial injuries do we need to deal with? Is there something else do we need to deal with? What potential complications can we have? Yeah, remember, I'm talking per the SOPs and everything like that. But if, again, if there's enough people on the scene where somebody's bagging and your sole job is, I'm the guy intubating, I have time to get ready to do it. While you're getting your stuff ready, you want to plan and think about what potential complications you might have. And as it says there, that pre-oxygenation gives you that little bit of time. Crew placement. Again, you guys know capnography, 100% sensitive, 100% specific for that you're in the right place. Almost. We're getting close. Again, so just reinforcing what we've been saying about capnography. As long as you have a good waveform, where We're not looking at the number at this point, right? We're looking for that waveform. And after 7 breaths, if you still have a good waveform on your capnography, that tells you you're in the right place. Why do we have to wait for 7 breaths to go by? Huh?
Get rid of CO2.
Get rid of any CO2 that might be in the stomach that might be giving you a false. Visualization of passage through the vocal cords. How many of you guys, when you do your notes, be honest, how many of you guys actually document in your narrative that you visualize the ET2 passing between the vocal cords?
There's a checkbox for it, so we don't have to write it.
Is it? Okay. Because that is vital, because, if it goes to court, they're going to say, so you didn't see it go through the court, so where did it go? Right? So again, a lot of times when we say this is all, defensive charting. Yes, I saw it go through, and I want to make sure it's on paper. So and again, if you read an anesthesia note, every anesthesia note you read in the hospital, or anytime anybody's intubated in the hospital, they always put that phrase, that they visualize the tube passing between the vocal cords. Okay? So if you're not doing it, or it's not getting checked, please make sure you're doing it. Again, it's all to help protect you guys. Make sure we're listening to lung sounds, absence of epigastric sounds. Secondary, now we want to look at that number for what's our interstitial CO2 levels. And again, that's telling us how well is ventilation taking place, how well is cellular metabolism taking place, right? Oximetry. Why don't we like oximetry as well? Why do we like capnography better than oximetry? Which one responds faster? Capnography. Capnography, you're going to see an immediate change, right? Because it's the amount of exhaled CO2. Pulse oximetry talks about the amount of blood that's saturated with oxygen. That can take up to 2 to 4 minutes to respond. So again, capnography is much quicker in its response. Drug-assisted intubation, failure to maintain adequate airway, actual or pending respiratory failure, GCS of 8 or less, inability to ventilate or oxygenate, or anticipated patient deterioration due to airway and imminent risk of closure. Give me a couple examples of when you might see airway and imminent risk of closure. Anaphylaxis, what else? Burns. Okay, those are the 2 we usually think about with those. Those are the ones we want to act early to make sure that we can get an airway in these patients. Let's see, routine medical care, pre-oxygenate, lidocaine for increased intracranial pressure, head injury, stroke, and hypertension, pre-medicate with lidocaine 1.5 milligrams per kilograms. What's our pediatric dose of lidocaine for drug-assisted intubation? 1.5 milligrams per kilogram. Remember, typically, most of the time when we talk about weight-based, it's going to be the same adult and peds. In the new SOPs, fentanyl is going to be 1 mic per kilo, period. Right now, it's 0.5 for kids. We're increasing it so that it's going to be the same. Okay? Etomidate, 0.3 milligrams. IV push IO, what's our pediatric dose? 0.3. Maximum dose, 20 milligrams. 20 milligrams times so what is it? So it's 68 kilos times 0.3 is 150.4 pounds or something like that. Okay? So 68 kilos, I'm sorry, 68 kilos times 0.3 is 20.4 milligrams. 68 kilos is right around 150 pounds. When you look at your patient and estimate their weight to be 150 pounds, you can stop doing math. It's anybody that you're estimating is less than 150 pounds, you have to do the math for. Okay? So 68 times 0.3 is like I said, 20.4 or something like that. So 150 pounds, no more math. Attempt to intubate, post-intubation sedation, we use Versed 2 milligrams. Every 2 minutes, titrate to desired effect to a maximum of 20 milligrams. When you talk about Versed, we use Versed in 4 SOPs. We talk about drug-assisted intubation, cardioversions, seizures, and behavioral emergencies. This is the only SOP that our maximum is 20. The other ones, it's 10. Why in those other three can we only give 10 milligrams of Versed? Drug-assisted intubation versus cardioversion, seizures, and behavioral emergencies. What do we have in this SOP that we do not have in the other SOPs? Protected airway. Okay, that's why we can go up to 20 in this. Now, in all of these SOPs that we're talking about, Versed, for cardiac arrest, or sedating our patients, you're going to see the new line that capnography is to be used. Okay, that's one of the things that we've also added, you know, in the SOPs, new SOPs coming up. Make sure anytime we intubate a patient that we're putting a C-collar on them, even if it's not related to trauma. That's just to decrease head movement so that for a patient. Fentanyl, 100 mics in 2, 1 mic per kilo. Again, max, and again, it's going to be worded. One of the things that's been confusing is each dose is only 100 mics. You can repeat it to a maximum of 200 mics. That's going to be spelled out a little more clear in the new SOPs. Pain relief. Some of the things to think about: skeletal wall, muscle, and chest wall rigidity. So if you're giving Versed to a patient in a small number of patients, you may find after you give that Versed, especially if you intubated them, it may be a little more difficult to bag the patients. Okay, so something just to be aware of. It doesn't happen a lot, but it does happen. Impaired ventilation, respiratory distress. Again, it can make patients more susceptible to laryngospasm and bronchospasm also. So just make, be aware of those as you're taking care of our patients. Okay, adult pain management. Again, fentanyl 1 mic per kilo, fentanyl 1 mic per kilo. Again, as I said in the new SOPs, the first dose will say to a maximum of 100 mics, and then you can repeat it to a maximum of 200 mics. Okay. If respiratory depression occurs, Narcan 2 milligrams IV push on or IO. So again, something to think about is if you give somebody pain meds and they start having a little bit of respiratory depression, okay, look at your patient and decide what's the best for them. If they're just going to need a little bit of support, do we want to reverse that fentanyl? No. Because that means until that Narcan wears off, there's going to be no pain relief that we can give them. Okay, so I know what the SOP says, but look at your patients and decide what's the best. Hey, just need to give them some extra oxygen, we need to support them a little bit, but we think that's better than taking this guy with significant trauma, making him suffer for the next 30 to 40 minutes or at a minimum until the Narcan wears off. So again, I know what the SOP says, but we're looking for you guys to make the calls on what's best for your patients. Okay? Yeah, this guy completely stops breathing, then he gets reversed and we take care of him. Okay? But again, if there's just a little bit of respiratory depression, figure out what's best for him. Okay? See, adult nausea management, Zofran, 4 milligrams IV push or 4 milligrams oral. Who gets oral Zofran versus IV Zofran? What's going to be your determination which one you're giving?
Age and alertness.
Well, age and what else?
Alertness.
Yeah. Well, also, do they need an IV? If you just have somebody who says, man, I'm really nauseous, I'm really nauseous, I'm really nauseous, do they necessarily need that IV versus that person who's been throwing up for 3 days and they need fluid resuscitation also? So giving somebody somebody that's nauseous necessarily might not be an indication to start an IV. Okay? Remember, we only need to start IVs if it's indicated. Now, if they haven't eaten for 3 days because they felt nauseous, yeah, they're probably going to be dehydrated and need some fluids. But that other person that's just, isolated nauseous, again, we don't want to start IVs that's unnecessary. And again, the nurses ordering an IV because you haven't started one. If you didn't start it because you didn't feel it's necessary, the nurse saying you can start one doesn't make it necessary either. Okay? Again, if you run into issues where, hey, this patient doesn't need an IV, but the nurses are saying it, don't get in an argument with them, but let me know. Okay? Or if you're going to Skokie or Evanston, follow up with their coordinators. I don't know the name of the new coordinator at Evanston. Barb is gone. They have a new MS coordinator at Evanston. Long last name. Martha sent us an email. But again, you know, if you don't think an IV is necessary, you guys are with the patient. That ECRN shouldn't be saying it's necessary just so they don't have to start it. Again, if you run into that, it's not making a big issue, but you know, follow up with the EMS coordinator at the hospital you're transporting to. You don't need to do their work just because they don't want to. Okay? Remember, I'm in there saying that. So. And when I teach the ECRNs, I tell them the exact same thing. It's not your job to start their IVs if it's not necessary pre-hospital. So hopefully that's getting to the ECRNs and their education also. Lidocaine comes 105. Oh, by the way, speaking about these meds, I don't know if they shared with you, but right now there is a shortage of lidocaine, epi, dextrose, calcium, sodium bicarb, and atropine. And what it has to do with is the company that makes the pre-filled syringes and getting them to Pfizer. And the problem is there used to be two companies, Pfizer and Hospira. Well, Pfizer bought Hospira, so really there's no one medication, one company making the pre-filled syringes. So if you remember, we went through this exact same shortage like 3 or 4 years ago. So if they have to, they'll give you vials of D50, the 50 cc syringe, and you would pull it up yourself. If we need to get you guys the epi, you get the epi 1 to 1,000 with the syringe of saline so you can dilute it. If you remember when we went through this before, the doc said atropine is not a life-saving medication. If you need to, you just go right to pacing.
That's right.
Okay? So again, was this shared with you guys that you may be running into some of these shortages? Okay, because I shared it with Paulie last week and stuff. So again, while we're here, this is a good opportunity just to make sure you guys know how we're dealing with this stuff pre-hospital. So lidocaine, we use it, 2 uses for it. Drug-assisted intubation, we already talked about. Okay? IO insertion. When do we use lidocaine for IO insertion? In a awake patient that responds to pain. Okay? And what causes the pain? The fluid. When you do that flush, right, is really when we're going to be worried about it. So, the lidocaine for drug-assisted intubation decreases the cough reflex during the actual intubation process. Remember, when they cough, blood pressure shoots up. So if we're thinking suspected increased intracranial pressure, we don't want anything that's going to cause that pressure to go up even for that short period of time. Using it during the IO insertion, we're using it as a local anesthetic so that it numbs the pain inside the bone tissue, so when we give that fluid bolus, that they don't have as much pain. That's also why we like the humeral head more, because there's more space in there so the pressure doesn't get as high. Let's see, known sensitivities. Anytime you're giving somebody lidocaine, even if you're starting an IO on them, they need to be on a cardiac monitor before you do that. Okay, even if you wouldn't think it would be appropriate, because we want to make sure that they don't have any type of AV blocks going on. If they have an AV block going on, we give lidocaine and we shut down those reentry pathways. Now you put somebody to asystole. Okay, even when you're giving it for an IO where you're giving 50 milligrams over 1 minute, right? 50 milligrams over 60 seconds. It's still some of it will still leach into the bloodstream. So, and we still may have it. So anytime you're giving somebody lidocaine, make sure they're on a cardiac monitor and make sure that we don't have any blocks going on. So when we talk about using for IO insertion, it's 50 milligrams over 60 seconds, wait 60 seconds. What's our pediatric dose for lidocaine for IO insertion? 1 milligram per kilogram to a maximum of 50. Remember, we never go over the adult dose. There's only one medication we go above the adult dose, and that's what? fluids, saline, right? Now that we're going with 500 cc boluses, probably won't be able to say that much longer. So 1 milligram per kilogram over 60 seconds, wait 60 seconds, and then do your flush.
Get your health care. Can't always act.
Let's see, I don't know if this is hooked up to speakers.
Hi, this is Jeremy again, Mercy EMS. Now we're gonna take a look at the quick trach. Here's your robust, contains all the stuff you need for your quick trach, etc. Out there for you. So you open it up. Bring the contents out. The holder. You have your needle with your trach on it and your tube, pipe tube that attaches to your BPM. So, find your landmark, okay, your cricothyroid membrane. Clean it off with your alcohol prep. You're going to advance your needle through the cricothyroid membrane in a kind of a downward motion. Okay? So the natural curvature of the needle is going to go towards the foot. Got your landmark, it's clean. Advance through. Up.
That's a well-used.
Make sure you have air.
Now, you're gonna
Yeah,
stop
right.
once that red hump touches the
Hold it here.
skin, and then you continue what he's
Needle out.
doing.
Goes into your sharps. Gonna keep it stabilized while you attach your breathing tube, your end-tidal CO2 bag. Make sure you have positive waveform. Make sure you're in the right
Now,
spot.
hopefully your buddy would be helping you with
And you
this.
can use your
Gary don't need no help.
stabilizer Velcros around one tab around the neck.
What are indications for quick trach? Inability to ventilate with other measures, okay? What would be contraindications to using quick trach? Hole in the neck, what else? What are we looking at with kids? What's a consideration for kids when we're thinking of quick trach?
You got no net.
So, let's talk about what's next. If we can't use quick trach, we have the needle cric. Okay, this is indicated for patients where we can't use a quick trach. Patients less than 22 pounds. So again, if they're less than 22 pounds, you cannot use quick trach. We have two sizes, right? We have the 4 millimeter and we have the 2 millimeter for quick trachs. Okay, but kids less than 22 pounds, we have to use needle cric. Okay, one things to think about whenever you're using a quick trach or you're using a needle cric is how quickly do you want to bag these patients? You want to squeeze these bags relatively slow because it's like blowing through a tube, right? The more pressure you put through it, the faster that air is going to come out on the other end. So especially with needle cric or using a 2 millimeter quick trach, you don't want to squeeze the bag real fast because you're going to be pushing that air out and you increase the risk of barotrauma or trauma to the tissue just from the velocity of the air. So again, just think of what we're using and the processes involved when we're using them. We don't use this. Has anybody used a quick trach on a real patient? Anybody do a needle cric? Anybody do a surgical cric if you're in another system? So we don't do this very often. Okay. Again, I think out of everybody I've asked in the system, I think I've had 2 people use quick trachs, and they didn't always go so well. But so again, just think, especially when we're using stuff, what we're trying to do with them. So needle cric.
The larynx is located and stabilized, preventing the trachea from lateral movement. Locate the Adam's apple. Prep the area. Slide the index finger downward to locate the cricothyroid membrane. Insert the needle through the membrane, maintaining a 60-degree angle caudally while aspirating the syringe. Once the needle has entered
It's
the
amazing,
trachea,
they switched
air
to
will
the
be
dummy now,
aspirated
right?
into the syringe, confirming that the tip of the needle is properly
It's
located.
not like the IO where they usually
Advance
have
the catheter into the trachea an additional inch. Remove the syringe and the inner metal needle, leaving the plastic catheter in place. Care must be taken to avoid kinking the Teflon needle.
Okay, so here they connected it to a positive pressure device, okay? What would you connect your catheter to? A 3 or 3.5 millimeter ET hook. Okay, and then you would connect that to your ammo bag internally, right? And those should be in the needle crite kit, all right, where it's got the needles, the 3 and the 3.5 adapter, and then the tubing there, okay? Okay, real quick, I want to talk about this. So what's happening is we're seeing more and more of this overseas, and there's actually been one car ramming attack last year at Ohio State where there were like 12 people run over. This is getting a lot of push. Actually, it was in last month's article of GEMS. Okay. Homeland Security actually just sent something out that I actually sent out to the medical officers yesterday, warning, and again, the notification of this type of event. Okay, and think about, with all the summer festivals and all the parades and everything we have, this is a type of attack that doesn't take any planning, doesn't take anybody assistance. All it takes is somebody just to hop in their car and do this. So there's just a couple considerations, that we want, you guys to be aware of. We've seen increasing frequency overseas. I think France, Israel's been hit a lot. Yes, I know I spelled Israel wrong. We're seeing more and more over in France. Yeah, the Jewish guy spelled Israel wrong. But we're seeing it more and more in France. And again, it takes no planning. So some of the things is, we're also working with some of the dispatch agencies to make sure when they get calls, are they asking the right questions? One of the things they should be asking is, did the car stop? Because generally if it's an accidental, where somebody hits somebody or goes into a crowd, that car is going to stop. Versus these car rammings, these vehicle rammings, where they just will continue on for blocks or as far as they can. Right, the one in Sweden was last month where they drove through the crowd into the department store or something like that. So we're starting to see this more and more. And again, this is just to make sure you guys are aware of some of the considerations to be aware of. Consider that this is an ongoing attack. This is their scene awareness. Okay, a lot of times they found that these guys either have the one in England last month. The guy hopped out of the car after driving across the bridge in front of Parliament and stabbed that police officer to death, right? But he had the knife. Others have been found to have guns or bombs. So is the car ramming the only thing you're dealing with? Again, he spread over a very large scene. Okay, it was in France, was on Bastille Day, where it was like 2 blocks that truck plowed through the crowds. I think killed about 60 people and wounded like 200. Make sure when you're responding, check under the vehicle for people that may be trapped. Check inside the vehicle. Maybe they carjacked the vehicle and the driver of the vehicle or passenger are still inside the vehicle. So what's going on? Okay? Remember that this is going to be a long distance. Again, like I say, if it's an accident, most people will stop. But this could be blocks, hundreds of feet, blocks long. A lot of the times we're seeing a lot of significant internal injuries. And one of the things is when you think of the article that I got this information from was written by somebody in Israel. They spelled it correctly in that article, by the way. But he was comparing this to bombs. Whereas when you talk about explosions, as you get further away from the incident, the injuries get worse, get better, you know, aren't as severe. And these types of injuries, because that the force is applied to every person exactly the same, you're seeing those severe injuries the whole length of it. Okay? Most ramming attackers use private civilian vehicles. Again, they can use trucks. Some of the big ones overseas, they've been using delivery trucks and stuff like that to do it. Again, it's getting a lot of attention in the States because it's a very quick and easy. We can turn that off, please. Just on the side, hit the red button there. Yeah. Yeah.
Where?
Good job.